I'm joined here today by Dr. Gianluigi Bisleri, cardiac surgeon at the Kingston Health Sciences Centre and associate professor at Queen's University School of Medicine. So thank you for making the time. To start us off, why don't you tell us a little bit about the common heart diseases that you encounter in the OR?
Yeah, so in cardiac surgery, we can deal with different kind of problems on the heart. Sometimes the problems are happening on the outside of the heart, for example, coronary disease, and sometimes they are happening inside the heart. And one very common problem that is deemed to affect about 5% of the population is called mitral valve disease. The mitral valve is a very important valve. It's positioned inside the heart on the left side, between the two chambers of the heart, the upper chamber that is called the atrium and the lower chamber that is called the ventricle. And this valve allows blood flow to move only one direction. That means to move forward. But when you have a very common problem that is called mitral valve regurgitation, very often patients may know as mitral valve prolapse, blood flow is moving backwards rather than moving forward.
That sounds quite serious. Can you tell us more about how mitral valve disease affects your patients?
So, since the blood flow should always move forward and never backwards, anytime there is an incomplete closure of the mitral valve, blood tends to sit in the heart longer than normally should, and thereby the heart over time tends to become larger. So obviously there could be a condition called heart failure that could develop over time. Plus, the fact that blood flow often tends to even move backwards, more blood could potentially sit in the lungs.
And what kind of symptoms indicate a dysfunctional mitral valve? Like how does the patient feel and how do they know that this is something that they're experiencing?
As mentioned before, the presence of the leaking mitral valve can lead to several clinical conditions. Actually, in the first stages of the disease, patients may actually experience no symptoms at all. So patients may be what we call asymptomatic. So they may feel a slight reduction in their capacity of dealing with daily activities, but not too bad. The heart has an incredible capacity in accommodating the extra blood into the heart and actually trying to overcome the leaky valve. But over time, this problem is becoming more serious, and at a certain point, the enlargement of the heart, leading, as we mentioned before, to heart failure, is actually bringing more limitations in the daily activity of patients. So patients are going to become unable even to walk stairs, and sometimes to walk also the extra miles that otherwise would have done differently in the past. Another important symptom that is related to mitral valve regurgitation is also the shortness of breath. So patients have now limited stamina, but also more shortness of breath even with limited exercise. Finally, another potential complication after severe mitral regurgitation is the occurrence of a common irregular heart rhythm that we call atrial fibrillation. And this leads also to the perception of palpitation by patients. So patients feel quite uncomfortable when atrial fibrillation occurs. At the very end of the mitral valve disease, patients can actually experience a complete dysfunction also on the right side of the heart. So this is definitely something that we want to tackle rather early than late.
What type of tests are done to determine that the patient's mitral valve is truly what's causing these symptoms?
So when a patient has the symptoms related to a leaky mitral valve, as we just discussed, it's important for him or her to refer to a physician quite promptly. The diagnosis could be already done by the initial visit by listening to the chest of these patients, and we can typically appreciate a murmur, which is the result of the leaky valve. Now, being able to find a murmur in a patient doesn't necessarily lead to an operation, because we need to have a very precise assessment in the amount and the mechanism of the mitral valve regurgitation. So we need more precise tests, And the key ones for us are represented by the echocardiogram, which are an ultrasound specific for the heart. We have a first line ultrasound of the heart that is called a transthoracic, which is a surface ultrasound, and it allows us at least to define if the amount of leakage is severe or not, which is for us a critical time point because that leads us to the next step. That means a potential indication for surgery. Now, when a patient has been found to have a severe mitral regurgitation, the second step is usually to have a transesophageal echocardiogram, which is somehow a bit less pleasant test for the patient because we need a more precise understanding of the mechanisms leading to the mitral regurgitation. And the transesophageal allows us to specifically analyze each component of the mitral valve and being able to understand also if and how we can potentially repair and tackle the problem.
So once you've determined that the mitral valve isn't functioning as it should, what are your next steps?
So that's actually a key change in the surgical practice over the past decades. At the very beginning of the surgical experience, and I'm talking about some decades ago, obviously replacing the valve was the norm. So the valve was not functioning, we were just removing the native valve of the patient and replacing with an artificial valve. Now obviously having an artificial valve can also lead to potential complications long term. So ideally, if we could repair the valve of the patient, maintaining patient's own valve, that could be the best option for us to offer to our patients. So this is what the surgical community has been working very strongly over the past decades in order to refine the surgical techniques and to being able to offer a repair which is durable, which means can last over time. So despite initially the valve was not working well, our repair can provide an almost equivalent duration and like a normal valve for a patient. The repair techniques can obviously be quite complex. So this is why it is very well established in the surgical community that it is advisable for patients to refer to centers where there is an expertise in treatment of this complex problem. We are very proud here at Kingston Health Sciences Centre and Queen's University to have a very comprehensive center for the treatment of mitral valve disease, which encompasses the collaboration from cardiologists that are running the test to define the mechanism of disease, to collaboration also with other interventional cardiologists for more collaborative forms of treatment of mitral valve disease, and obviously surgeons offering the possibility to repair these valves. It is quite tricky and sometimes it's not as straightforward, but we have nowadays the capability to offer a high chance of repair, which means we can repair valves in about 90%, almost 95% of cases, even in presence of complex situations. And most importantly, these repairs are likely to last very long over time.
What are the minimally invasive procedures that can be done to minimize trauma to the patient?
Traditionally, the surgical treatment of mitral valve disease has been performed using the most common incision in cardiac surgery, which is the median sternotomy. It means a big cut that is performed in the front of our chest. This is obviously a very safe option, a very effective option because it provides the maximum access to the surgeon, but obviously is not so appealing for the patient themselves. It can obviously be associated with an increased trauma and not a very fast return to a normal daily activity. Now, over the last 10 years, there has been an intense activity in the surgical scenario in order to provide patients with less invasive approaches. And what does it mean? It means that we can avoid an incision in the front of the chest and we are able to operate patients just by performing a very tiny cut, like a keyhole access, just between the ribs. And this is obviously very convenient to patients because we can allow them to return quite quickly to their daily activities. So the quality of life and also the pain is significantly reduced. It obviously makes the procedure a bit more challenging for the surgeon. This is also why it is not commonly offered in many institutions, because on top of what we discussed before, that the surgeons must be proficient with the different surgical repair techniques, you now need to perform such repair techniques without directing access in the heart. So we have specific designated cameras and instruments that allow us to reach the inside of the chest. So that's really an important step forward that we started more than 1 year ago to offer here at Kingston Health Sciences Centre and Queen's University, and we are continuously expanding the possibility to offer these to our patients. Now, many patients may benefit from this approach. Some patients may not have obviously the indication for this approach. What is important is that the fact that we can offer the full spectrum of possibilities, we can tailor the best treatment according to the specific patient needs. But obviously with a continuous drive and interest towards less invasive procedures. I'm also quite excited to share with the audience that we are in the process of starting soon even the use of less invasive approaches that imply the adoption of a robotic platform, which can greatly improve our dexterity during less invasive procedures. So this is something that, again, in selected patients we'll be able to offer here in Kingston, and that will allow to broaden even more the possibilities to our patients.
Thank you very much for your time. I'm sure that the audience and myself both gained quite a bit from this discussion, and I look forward to our next one. Thanks.